Good afternoon, everyone. This is Terrell Eisinger with the National Organization of State Offices of Rural Health. Thank you very much for joining us today. You've just seen a depiction of the State Office of Rural Health work. We are celebrating the 25th anniversary of the State Office of Rural Health program from the Federal Office of Rural Health Policy, and we are very proud of the work that the State Offices of Rural Health do every day. The National Rural Health Day activities actually began with a vision from State Office of Rural Health Director Karen Madden from the state of New York, and it's been the work of those offices across the country that has helped National Rural Health Day grow. I'm really happy to say this afternoon that we're seeing the Power of Rural trend on Twitter. Thanks to all of you for helping with that. I also want to say a quick thanks to the NoSource staff, Ashley Munninger, who's done our social media work and worked with the press, Matt Stricker, who has worked to coordinate these great webinars, and also thanks to our communications committee, and also to Cassie Clark, who published a great ebook today on Community Stars. So I hope you'll continue to watch for all of that. As we're beginning, I want to remind you that the purpose of National Rural Health Day is to honor good work being done, the fact that rural communities are a great place to live and work, and to shout out about the needs of rural America. So as we begin this webinar, one of the things I'd like to reflect on really quickly is that the use of data has been something that I've watched just in the last 5 years really become so important. Our staff, Chris Salyers, is working with a very invigorated team that grew out of the University of Wisconsin State Office of Rural Health. Ms. Penny Black took a leadership role and received an award from us this year for her work with launching a data institute. And we're proud of that. But I think what I'm most proud of about the work is that I've seen the state offices and the state flex programs really dig in and have an important role in providing technical assistance to help rural providers participate in important programs like MB-QIP, and they'll continue to be a lead in future efforts for data. So we're very happy today that Dr. Samo can join us and share with us some great information about the use of population health and the use of data. And with that, I'll turn it over to you, Dr. Samo, and thanks again for joining us on this day.
So my pleasure, and thank you very much for inviting me to participate in this. I have to admit, I was not aware of a National Rural Health Day, and was excited to see the work that your organizations have been doing. just a small background for me. I'm a practicing physician. My specialty is infectious diseases, but I have been a, uh, a closet geek for many years and have been able to bring together the two passions that I have, which is medicine and computers, to be involved as equivalent of a CMIO at the hospital in Houston, at Methodist Hospital, and then have been involved with development of various healthcare IT products. And through this work, I've had a chance to get more involved with the policy and directions as to where healthcare is going, and was one of the reasons that now most recently I've become involved with the population health management, since I see this as a very strong direction as to where healthcare is heading. So I think, many of you are aware of what is now affectionately called as the triple aim. This is a concept that in order to improve healthcare on a broad level, it takes three legs of the stool. Certainly better patient care, something that all of us can agree upon, that we want to ensure that our patients get the best care possible, the highest quality of care. But not only individual patients, but now moving into the population itself, so that we understand that in order for healthcare to be able to be accessible to everybody and to have a positive impact, if we can improve the population, improve the health of the population, that will go ahead and lead to better cost savings and better quality of life for the population at whole. And the third leg of that stool is lower costs. Something that we're not very good at here in the U.S., despite the fact that we spend more per capita, almost twice as much as per capita as other developed countries. We typically rank towards the on the low end, 25, 27, and a variety of health parameters, so that cost alone is not a harbinger of how well somebody will do. So there has been a significant push across the healthcare environment to move towards the triple aim. And one of the ways that this has been done is through population health management, or value-based care is another term that you'll see used. And there are estimates that 70% of lives will be covered by some form of value-based care. And we'll talk a little bit in a few minutes about some of the different variations. There is no one population health management system, no one value-based care model that's been effective. We're seeing a push from CMS. Their innovation center has had projects around accountable care organizations, value-based purchasing, bundled payments, where the full cost of a certain encounter is all included, is now becoming mandatory for certain types of procedures, most specifically joint and hip replacements. We're seeing primary care transformation models, et cetera. Medicare Advantage is, I think, many of us know groups that no longer take regular Medicare, only Medicare Plus or Medicare Advantage patients, and other processes such as the chronic care management model. And not that I want you to necessarily understand what all of these different models are, but to comprehend the tremendous variety that exists, and therefore the push that is coming in order to see that the way to get to that triple aim is not only through, but one of the major roles is through value-based care. One of the terms that I'm sure many of you have heard quite a bit of lately is called MACRA. That's an act, the Medicare Access and Chip Reauthorization Act, that happened in 2015. There's been a lot of confusion about the terminology associated with this, But this is a very good example, as you break it apart, to understand how the models are developing so that not only so certainly those healthcare providers that are organized as an ACO or a patient-centered medical home bundled payments, that they can participate in this value-based care and benefit by having bonuses attracted. And that's what's called the alternative payment models, the APMs. But in addition, this merit-based incentive payment system, or MIPS, says you don't have to be part of one of these large entities with an ACO, that you can participate in this value-based care model, even if you are in the fee-for-service world still. And it also goes ahead and combines several other programs, the PQRS, value modifier, even the infamous Meaningful Use project has now been combined into the single program of MIPS and of the MACRA in general. And what this counts upon is that bonuses or eventually penalties can be encountered based on a scoring system. Believe me, this scoring system is complex to understand. That's not the purpose of today, but to understand that the quality, cost, clinical practice improvement, and continued meaningful use of the EHR are going to be measured and calculated, and a score obtained, and based on this score, the provider can either be penalized or gain a benefit from that, get a bonus. So let's make some predictions about some of the things that we're going to see in healthcare in general and how they impact in rural care. So physicians clearly need to take the lead in the delivery of value-based care. This has to be clinically led. Certainly, you will need to go ahead and have administrative support in order to participate this, but ultimately the goal is to ensure better care of our patients and better health for the population. And so physicians need to take that lead and to be supported by the various administrative responsibilities. So for instance, the patient-centered medical home has shown in the past, has been shown to improve quality and cost of care. And so some physicians are finding, because of the pressures that are identified in some of the administrative, let's call them hassles or administrative requirements that are necessary, that some physicians are moving into larger group practices so that they can share that administrative burden. However, there are models that will allow individual practitioners and small groups to maintain their independence, and MIPS is an example of that. Even a solo practitioner can participate in the MIPS program and does not have to be part of a large group. So whether or not it's the MIPS program participating as part of a clinically integrated networks, some IPAs are taking on administrative roles to allow the members of their independent physician associations to actually go ahead and participate in those programs as well. The bundled payment is another example of where that can occur. And in order to ensure that we see that this work of improving quality of care and reducing cost, we're going to see a marked enhancement in the general term team care. So the team needs to be clinically led, predominantly by a physician, although other providers can also take the lead with this. depending on what the situation is. These teams are typically multidisciplinary: physician, nurse, nurse practitioner, or physician assistant, case worker, social worker, case managers, pharmacists, other therapists as well. And so in order for these care teams to be successful, there needs to be a lot of communication between providers, between various team members, as well as other teams within the network. So understanding and identifying those leaders that can truly lead a team is a skill that in many ways has not been encouraged or fostered in our educational experience. But I think that we're going to see that team management is going to become more important. So as an example, my son has decided, poor demented soul, that he wants to go to medical school. So he's in the process of applying, and the MCATs now have a new section on critical analysis and reasoning skills, and another section on psychological, social, and biological foundations of behavior. And they're using students to broaden their expertise outside of the purely medical scientific, to understand the responsibility and the importance of interdisciplinary and interpersonal skills as well. So we're going to have to go and take a look at bringing these populations together. So if you have a team, what are you going to use for this team? That we're going to see new delivery strategies. So for instance, we typically think about the patients that are sick or that are coming into our office on a regular basis or come once a year for their physical exam. But we also have to, when you start looking at population health, have to consider that there are some patients, and you may see them called members or clients, but being the clinician, I typically consider them patients even if they're not sick. But you'll have patients that you are responsible for who will never set foot in the core facility. And we're going to see more and more care being dispersed further out into the community. And I think in the rural area, that will get to be even more important, where there are great, distances that need to be dealt with. And somebody to come in for a wound check, a week after surgery, you have to drive an hour to do that, versus being able to go onto the web or just take your phone and open up an app and show a picture and you see that the wound looks well. So new care delivery strategies have to be considered. Some of that has to do with reimbursement, and some of these models will go ahead and take that into consideration. But I think that also goes ahead and points out that some means of unified communication. So, it used to be letters, then it was the phone, then email, now texting has become very important. All of these different forms of unified communication play a role in the spectrum, plus is going ahead and considering how does this particular patient want to be approached. I like email. My son doesn't look at emails. He only looks at his texts. So to be able to identify so that you are getting the best engagement with the group of patients or the population that you're responsible for. In addition, non-physician providers, I mentioned already earlier, nurse practitioners and physician assistants, and I believe they play an extremely important role, as do the nurses, but also I think frequently forgotten or let's say at least not appreciated as much as they should, the pharmacist. Somebody comes into the pharmacy maybe several times a month while they only see their doctor every 3 months or every 6 months. So the pharmacist should be involved with understanding that longitudinal health record. Same thing with therapists. So if somebody's getting physical therapy, they can be the eyes and ears that exist. So which also goes ahead and brings up other community programs. They don't necessarily have to be medically trained. What about if you have somebody that's participating on Meals on Wheels, that somebody can, who's delivering the food, can go ahead and have a means of contacting somebody in the care team to let them know that this person who I've been delivering to, something is not right. So we need to expand what are our concepts of where people are treated and who is part of the care team. As part of that care team, we're calling this expanded group of patients care circles, where these different eyes and ears and these different providers are connected, and through an app or apps using electronic communication to its fullest. And this also includes family members, an elderly patient, the children in the family, or somebody who's the mother of a child, et cetera. All of these are part of what we call care circles, and we need to take full benefit and allow communication between those members of the care circles. And this brings us to consumerism in general, where we need to rethink patient engagement strategies. Patients are much more price sensitive as they are being held responsible for larger portions of their bills. And, they would rather pay $35 or $25 for a telehealth contact rather than have to, drive in, even if the copay is less, the convenience of doing that from the comfort of your homes in an advantage. And the last on this slide is what is typically called the Internet of Things. Don't ask me who came up with this term, but it's the concept from the medical perspective of devices at home that connect to the Internet. So whether or not they be glucometers for the diabetes patients or a scale that is connected to the Internet for somebody with congestive heart failure, a blood pressure cuff for somebody with hypertension. And this information then is not just done on the device, but connected wirelessly. And there is technology that makes this very simple to do, so that this information can now be brought into this larger database. And there's a lot of data that is being brought in by all of these different variety of partners and members of the team that we've talked about. And so what happens with all of that information? So we need to bring that data to the appropriate individual. Does not necessarily mean it's the physician, in a meaningful way, so that the information is presented in a way that now makes a lot of sense. So this brings us to data. Data. We hear about it. It's great to hear that your society is working on collaborating to bring that data together. And there is huge roles for data. There's new frontiers in multiple industries coming around data, and there's a lot to be learned and gained by these sophisticated analytics of these huge sets. But in some ways, I think physicians may reject big data. Not all of it, because this may sound heretical, but physicians will reject some of the big data initiatives because what they need is focused data. So to be able to have somebody take these large troves of data and say, what is it that I need? Not only do I need data from my EMR, but I need data from other providers and members of the care team. I need data from claims, from pharmacy. Socioeconomic sources are being identified as being valuable as well when we start looking at big data. So physicians are eager for actionable data that they can use to inform decision making. And the other aspect of it where that reporting gets to be really important is that what you report is going to have an impact on how you are reimbursed. And all of these quality programs and where there are bonuses that are available depend on reporting. So tools that are able to take that data that has been collected, sort it out so it gives to the provider the focused and clinically important data that they need, and then to be able to report upon it is going to be vital. And technology is going to be help with us to do that. The EHRs play a significant role. The Meaningful Use program, to my mind, accomplished some of its important goals, which is getting what was a lot of unstructured data into structured format so that it can be evaluated. But there's still obviously usability issues associated with them, and there's interoperability issues that are associated with the EHRs that many of them don't play well with others. The growth of cloud-based solutions are going to go ahead and help accelerate some of this or help alleviate some of these problems because they are much more cost-effective and able to be distributed in a much more general way. So in order to be able to really play within the population health management solution, you need some sort of platform that you can see here in the center that allows you to aggregate data and normalize it from multiple different sources, do analytics and risk stratification to identify the patients that need attention, use care management techniques and coordination to manage better those patients that are high users, get patients involved with their patient empowerment and engagement, and then go ahead and do the reporting skills. Now, you don't necessarily have to have all of these capabilities, and because each situation is different, but these are areas where the EHR may not be effective. And there's an opportunity for organizations to go ahead and take a lead in supplying some of that underlying structure and infrastructure to individual healthcare providers out there. And in the last minute that I have here, I think value-based care and rural health really have a good fit together. There's a strong sense of community within the rural health communities, caring for each other and supporting each other. People know each other. There may not be as many providers as you and variety of providers that exist out there, and so therefore good communication between the providers and a strong primary care physician tradition exists, or primary care provider already exists within the rural communities. And lastly, there is a geographical challenge of distances and therefore benefiting especially from some of those new models of care delivery, unified communications, broader use of telehealth, and broader use of other providers are all areas that I think that the rural communities are well ahead of other areas. So with that, I hope that my purpose was not to scare people, but to get them to understand that value-based care is here. We need to be aggressively pursuing and getting prepared to do that. And it's for reasons that's going to lead to better care for your patients and for your population as a whole. With that, I'd like to thank you, and I don't know if there's time for questions.
Thank you, Dr. Samuel. This is Terrell Eisinger. Just if I could take what you presented today and play it to every urban tertiary care provider and every insurer across the nation, and then add the footnote that state offices of rural health have been working and have been at the ground level of ensuring connections to primary care, about integrating value-based purchasing methods, about really building the base from which all of this can happen. So I'm glad to hear that you understand that, and we can use that message to really help rural providers understand their value in this value-based world that we move to, because we can't provide better care at a lower cost for more people without that transition. So thanks very much for your insight on that. I don't believe that we have time for any questions or chat, so I apologize for that. Going forward, this has been a great discussion this afternoon. We really know that this work that Dr. Samo is talking about does not happen overnight. We want very much for people to continue the work that they're doing, especially as they build innovation about making rural people and helping rural people to achieve their health goals. So that takes a lot of work, a lot of people coming together, and we're going to ask you to pledge to keep that work moving forward. We have a short video for you on an opportunity for you to make your commitment to that work public, and I hope that you will stay on for the end of the webinar when you'll be linked directly to a pledge for the power of rural. So Cassie can play that video for us now. Thank you.
Thank you for joining us in celebrating the power of rural. My name is Michelle Rathman, President of Impact Communications, and it has been an honor to work with the National Organization of State Offices of Rural Health to increase the outreach and awareness of National Rural Health Day 2016. As a part of our efforts, we've helped to develop the Pledge to Partner. It is now my pleasure to introduce this important initiative to all of you. The Pledge is a way for us to transform National Rural Health Day into a year-long, ongoing commitment to bring collective focus to specific healthcare issues facing rural communities across the United States. We're asking you to begin new conversations about the power of pioneering partnerships, and we need all rural health stakeholders to inspire communities across the country to address and resolve their most challenging population health issues. The Pledge to Partner focuses on 4 key areas, and these are: first, innovation. Commit to developing ideas, programs, and models that continue to transform and positively impact rural healthcare delivery. Challenge partners and community leaders alike to explore new approaches to reach at-risk rural populations, and engage thought partners from non-healthcare industries to help create additional solutions to prevailing health challenges. The next area of the pledge is focused on education. Initiate frequent discussions designed to inform stakeholders about the real issues facing rural providers. Inform those entering the field of medicine about the great and fulfilling opportunities to care for rural communities, and share facts and information about the needs to improve access and outcomes with those who influence policy and the allocation of resources. The next area of the pledge is about collaboration. Commit to forging new relationships that will bring additional resources into the rural healthcare fold. Please invite competitors to become those thought partners, helping to find synergies that result in achieving important shared goals, and then share ideas and resources and information with industry and non-industry contacts, seeking ways to work together in the common interest of rural health and wellness. The last piece of the pledge is all about communications. Use all available channels and mediums to spread the word about the power of rural. Follow, like, forward, post, and pin those stories and ideas and facts and opportunities and partner with all of those who are working to make a difference in rural health care. We're also asking you to really stay connected with NOSOR and your state offices of rural health throughout the year and help us reach the goal of 1 million people in social media platforms leading up to National Rural Health Day 2017. So there you have it. The 4 major areas of the pledge is to innovate, educate, collaborate, and communicate. And it's very easy to take the pledge by visiting powerofrural.org. There's a very simple form for you to complete, and when you hit the send button, you'll start to receive information for the rest of 2016 and into 2017, leading up to National Rural Health Day 2017. And the last thing we're going to ask you to do is, in everything that you do today with social media, please use the hashtag #PowerOfRural. Thank you so much for the opportunity to be a part of National Rural Health Day 2016.
Thanks, everyone. I hope you have a great day, and we'll watch for you on Twitter. Bye-bye.